Okay, let's move to the last speaker of the session. I'd like to introduce Professor Wen-Harn from Taipei Medical University. She worked in Academia Sinica for a long time, but she moved to the current position, College of Public Health, Taipei Medical University, as a Precision Nutrition Chair Professor since August in 2024. The title of her talk today is Optimizing Diet and Nutrition for the Prevention and Management of Geriatric Syndromes, Insight from Taiwan. So let's welcome Professor Pan.
Thank you, Mr. Chairman, for your introduction. It is my great honor to be able to speak to this audience for this very important event. I'm really happy that the NHRI now, this time, has nutrition as the focus for aging issues. Okay, so what I'm going to talk about today is to tell you a little bit about Taiwanese data with respect to physiological changes we observe with aging, and diet and nutrient intake levels, which is associated with geriatric syndrome, and some studies on dietary pattern associated with geriatric syndrome, and dietary quality quality and changes associated with development of geriatric syndrome. And this part, the fourth part is actually based on host NHRI study. Okay, and finally, I'll speak about some intervention study that we carried out in Taiwan. One of those are in collaboration with NHRI. Okay, first of all, let me talk about some physiological changes occur with aging, observing Taiwanese population. This data is coming from the Nutrition and Health Survey in Taiwan, which we have been carried out for a long time, and we used the 2013 and 2016 data for this part. Okay, as you can see, when people age, their height and weight are both decrease. So we probably think of increasing body weight and obesity, right, along with aging. But actually, when people age at very old age, their body weight decrease because these three color are those for the elderly, starting from 65 year on. You can see the very obvious drop of height and weight, and also you can observe the mean lean muscle mass also decreasing, and quite a lot for men. It's about 6 kilograms since the start of becoming elders, and about 2.2 kilos for women. And for frailty, you can see more, 6 kilograms for male frail men, and 1.5 kilograms for frail woman. Okay, and we even observe the hemoglobin concentration drop. It's actually quite a lot for 2 milligrams per DL for men. And for women, we observe that only after menopause. So it's not too much because women actually increase their hemoglobin concentration after menopause and then start to drop after they become elders. Okay, and at the same time, we observe changes of pulmonary functions. And I personally feel this is a very important risk factors. And we recently collaborated with Dr. Zhuang Shaoyuan in NHRI using prospective study and really finding out that pulmonary function is associated with frailty development. Okay, so that would be also very important. Gait speed, grip strength, all drops along with the aging, so which we all know for the phenomenon of frailty development. And also the MMSC score, mini mental scale examination, this score drop drastically from starting from one become elders, okay? Okay, so we observe this kind of physiological changes, and we know that older people, they change in their appearances. And this changing in appearances actually is coupled with the physiological changes in the intrinsic capacity, inner mechanisms, including immune functions, muscular, skeletal system, cardiovascular system, central nervous system, digestive systems. And it all starts in slightly different time frames. Some starts earlier and some starts later. But it results in a phenomenon we all call geriatric syndrome. You can see that it includes the mental, psychosocial aspects and physiological aspects or musculoskeletal aspects, not just frailty, sarcopenia, or falls, but also something like the bladder control, bowel movement control, and also chewing abilities. This kind of aspect, and also like I mentioned about anemia, malnutrition, and pressure ulcers. So today I'm going to use two major syndrome, that is dementia and frailty, to illustrate the points of the importance of nutrition. Okay, because of this failing or deteriorating of the human body for all systems and organs, and we have poor absorption, nutrient delivery and utilization, and probably inflammation and microbiota dysbiosis. So our body age. And is this an age, just a natural deteriorating course? Of course, men, everybody dies. So it's definitely a natural deteriorating course. But we do observe there are heterogeneities in terms of a total well-being and also the lifespan in elders. So that means there's something we can do, at least to delay the process. Okay, so today's topic, my topic, is to show you the understanding of the association between this accelerated or delayed aging and nutrition lifestyle. Okay, we are hoping with this understanding we can prevent prevent the accelerating of this whole processes using such as diet, physical activity, and sleep. I believe all three of them are very important, but I'm focusing on diet today. Okay, so I'm going to share with you some of the Taiwanese observational studies on quantitative and qualitative aspects of diet. With that two syndrome I mentioned to you. The first part is about a cross-sectional study we carried out using the Nutrition and Health Survey in Taiwan. And Dr. Li Shuzhen is the person who really managing the whole nutrition and health team. And Dr. Wu Siyun is one who carried out data analysis, nutrition epi research for many of my studies, and also Dr. Xiaoyuan Zhuang from NHRI is also my long-term collaborators. Okay, and the first very important study I'm going to share with you is about the adequate intake of protein. We all know all kinds of recommendations of how much protein the elder should eat, right? But what about the evidence? So one of the very important concepts in nutrition field is the adequate intake. That means when you don't really have enough information about the protein requirements for elders, you can probably collect a group of very healthy, non-frail, non-sarcopenia people and try to measure, analyze their protein intake compared to those with the syndrome. So you can see that for the elderly population, we separate them to three groups: frail, blue for the men, and the brown for the woman. Frail, pre-frail, and robust. And you can see their mean protein intake per kilogram body weight differs, and there's a trend. For men, it's from 1.34 drop to 1.26 to 1.11, and for women, similarly, there's a dropping trend. Even for women, it's 0.90 for the frail woman, and parenthesis is the value for median. So this can serve as a very important reference value for how much protein the elder should consume in order to avoid frailty. And you can also see that the distribution down there for breakfast on the top, middle, lunch, and dinner, and also the snack on the bottom. You can see that actually, even for the robust, their protein in the breakfast is not that too much. It's still a small amount, but they have no problems. So I guess the distribution, equally distributed issue, maybe is very important for those who are frail. But if they intake sufficient protein, they are okay if they, distribution is not that even. And you can also see that for the frail people, their protein source actually quite a lot is from the bottom. That is the snack. So that means those food are not healthy, even though with protein. So we're wondering about the importance of other nutrients in the diet. Okay, and so this part of the study, also carried out by Dr. Wu, is to see, in addition to protein, is there any association between frailty and also poor cognitive function with the other nutrients, micronutrients? And you can see here, using this data plot, you can see that for young, older men, those who are aged less than 75, there are multiple nutrients which are lower for the frail. The yellow in the middle show, and there are many, many nutrients, not just one. And you can see the lower part is, particularly in Taiwan, everybody is low, probably in B1 and zinc and protein and several things, magnesium. And for older ones, the difference is less in terms of number of nutrients. And just two, vitamin B6 and zinc, and showing that maybe more of a developmental issues, natural cause, than the nutrient deficient situations. And also for women, you can observe the similar kind of findings. Multiple nutrients are much lower, yellow, for the frail woman. And the number of nutrients involved are less for older or old woman than the young old woman. Okay, and similar, we can see that for cognitive impairment. We also see the yellow color in the middle, showing those who are, cognitively impaired, have much less nutrient density in these four nutrients, and there are just two in the old men. And next slide, showing the cognitive impairment association with nutrients for young old woman and old woman on the right hand side. So what we observe here is multiple nutrients are involved, but I just showed this. I don't have time to show many slides. If we correct, adjust energy, this difference disappeared. So it's coherent with what we heard this morning, that it really is the less energy intake that is the major contributors, and there are probably 200-300 caloric difference for the cognition impaired with those are robust, and also maybe 100 to 200 kilocalories for frail and robust. Okay, so it's really the amount of food that consumed is really an issue. Okay, this is just putting all of them together. You can see the whole pictures. The yellow color is always in the inner circle. Okay, next then we like to tackle a different angle. What about the dietary pattern? We now know that appetite, amount of food is important, and a less amount of food contribute to less nutrients. Okay, and what about dietary pattern? Apparently, for the adequate intake of protein slide, we noticed that frail people eat more snacks. Okay, and we're using a reduced rank regression. It's a dimension reduction method, and using for this one, using the frailty score, Linda, the frailty score as a dependent variable, and nutrient component as the independent variable. And we found that the dietary pattern, you can see on that, including first of all fruits, and second nuts and seeds, tea, vegetable. Let's see, maybe here is easier for me. Shellfish, dairies, and fish. Okay, and this is protective, all with negative values. If we construct this into a score, and you can see on the right-hand side that with the higher number of this dietary score, protective score, you see the very dramatic drop of the presence of frailty, okay? For frail compared to robust, for pre-frail compared to robust. And so this dietary pattern, I think is familiar with many of you. You can see it in larger letters: fruits, nuts, seeds, tea, vegetable, whole grains, shellfish, fish, dairy. Actually, it's quite similar to the Mediterranean diet. It's just that we Taiwanese consume tea, not red wine. Okay, so basically, it's a similar things. Okay. Next slide, please. And so our study has been compiled with many other studies in this review, separating non-Mediterranean diet and Mediterranean diet. You can see that it shows overall there's a protective effect of this kind of a dietary pattern in relation to frailty. Okay. So next, I'm going to show you some of our study, try to relate dietary pattern with the score, MMSE, because the data we're using mainly is coming from Nutrition and Health Survey. So people are not really, dementia. They just have poor or higher, good or bad MMSE score that we use for the mental for this aspect. And you can see that for two dietary pattern we found for men and for women, it's quite amazing. It's so similar to the frailty dietary pattern. You can see that fresh fruits, nuts and seeds, whole grain, breakfast cereal, that is the oats, and coffee, dairy products, seafood products, and fish for men. And for women, very similar, starting from fruits, nuts and seeds, tea, eggs, whole grain, soybean products, vegetable, and coffee. So there's just a very slight difference, but you don't see much red meat there, right? And that red meat has never come up in this kind of analysis. There's always no red meat. And this study is carried out by Dr. Zhuang and others. And he actually using this dietary pattern to conduct a prospective study because, however, in the prospective study, we simply found fish and tea are protective, not many others. I think due to the duration and also because about 15 or 20 years ago, Taiwanese don't really eat nuts and seeds, and there's no whole grain available. So it's very hard to study this phenomenon. But luckily, okay, here's the pattern I summarize here. So you can see, again, it's similar to Mediterranean diet, except that we have tea and coffee pop out on this analysis, but not in the frailty part. Okay, so in order to understand prospectively how diet influence the development of frailty and poor cognitive functions, we are lucky to be able to use the data generated by NHRI, the Healthy Aging Longitudinal Study in Taiwan, initiated by Dr. Agnes Xiong. It's a very powerful study because it has a large number of sample size and also it's longitudinal. So we take advantage of this data set, and they are conducting the third survey, but currently we are able to use the two surveys, the baseline and follow-up. And I know there's a 5 years of follow-up. We can calculate the change of dietary score that we derived using reduced rank regression from the baseline and see the development of frailty and poor cognitive functions. And you can see the sample size is quite large for those with the MMSE 2500 and those with frailty score about 3,000, and half of those with improved nutrition and half those with deteriorating nutrition. And similarly for frailty and cognitive function. And for cognitive poor MMSE, the event is smaller, about 56 for the those improved the nutrition. Event is 97 for those with deteriorating nutrition. But for frailty, the event is larger, 635 for frail in the improved nutrition people and 700 also for the deteriorating nutrition people. Okay, so what we found for the dietary pattern, so we do this independently using this data set. And so we actually get very similar dietary pattern with the one we use Nutrition and Health Survey. You can see that the protective dietary factor is the more plant-based diet, fruits, dark green vegetables, nuts, whole grain, tea, and also allium. It's a spice we use and here for men, and for women actually very similar. But we also notice some risky foods, including refined grain, which is white rice, okay, and red meat, and baozi, bao, sweets, okay, and for men and women, similarly, refined grain, dairy, and sweets. Okay, and this is for MMSE, practically very, very similar. So we now know that protective dietary pattern actually is quite consistent with Mediterranean dietary pattern, and it's consistently coming out when we're using data mining approach with different data set. So what we found, I think what we found is very, very important. That is, if we separate people to poor dietary pattern score, median and good dietary pattern score, you can see that the for cognitive decline, there's a protective effect for those with improved nutrition or those with deteriorated nutrition score. And this is the same thing for frail people. And I think what is important is that no matter where you start in the beginning, whether it's poor, medium, or good, you see for the poor ones, your risk starting from 1 and drop to 0.73. And for those who are good, and 0.49, 0.5, and drop to 0.31. So in 5 years, so that means that no matter where you are, if you change, you improve your dietary pattern, your risk for the future development of either frailty or cognitive impairment would be changed. So it means that we can do something to change that. And most of the time we rely on intervention study to show this. But I think, personally, I think longitudinal study is very important, because when we carried out intervention, usually we cannot afford to do that for a very, very long time. So even though we have done that, and our previous speaker have mentioned one of the study we carried out in Academia Sinica in cooperation with NHRI. And so I'm going to that part right now. Okay, so I'm going to show you some of the two studies. One is a hospital-based dietary consultation trial. It is a randomized control trial, as I said, collaboration between Academia Sinica and NHRI. Okay, and first of all, we had the pilot study. We experimenting on customized dishware and food supplements, and to see whether we can reduce frailty and improve mental well-being. Okay, and we actually start with four group comparison, with control on the, sorry, this is in Mandarin, in Chinese. This is control, and vitamin and mineral powder, and protein powder, and this is dietary intervention. So you can see that most of the yellow color, which is the experimental group, have some drop in the frailty score, slight drop, but the only significance is observed for the dietary group. And we also observe there are improvement for the GDS, geriatric depression score. You can see that. So this is the first pilot study we did with, I think 60 people for this. And later, this study this approach is trialed, combining home-based exercise and nutrition intervention that I described just now. And the food supplements include milk powder and a bag of nuts and seeds, and which is sufficient for 3 months, for the 3-month intervention. And the home-based exercise, which is designed by Professor Xu, our chairperson today, which using freehand without tool, freehand exercise at home, and also they provide something like the band, the elastic band, and they do that kind of exercise at home, and which shows the result is quite good. You can see that for the top is the control, the blue color. The exercise group is the red color. You can see the score dropping, and the nutrition is the green color, and nutrition plus exercise is the purple color. You can see for the nutrition and exercise combination, the effect is the best. And it takes place after 6 months, even though our intervention stopped at 3 months. And so they are advised to purchase their own milk powder, their own nuts and seeds, but the plate we gave them a standard plate pictures so they can take home and to follow the plate instructions. And at the bottom you can see that the combination approach creates a 0.34 drop in terms of frailty score. It means that for every 3 person, at least 1 is improved. You can kind of think of that way. So this part. And what about nutrition effect? What happened to the diet? And actually, we observe about half a serving of protein food. We observe about 1/3 the piece of increase in terms of fruit, and also 60 cc of milk increase, and 1.5 tablespoon increase in nuts and seeds. Okay, so the change is really not too big for every fruit group, but if you add them together, it probably creates about 1 and 5 servings of protein a day. It translates into somewhere more than 10 grams, 10 to 15 grams of protein a day. With all this add up, and plus all the nutrients coming from dairies, from fruits, from protein-rich foods, and from nuts and seeds. Okay, and okay, following that, so we're thinking that is a dietitian one-to-one kind of a consultation. It's more costly. Or what if we can do it in a group activity fashion in community? So we have this study conducted in the community stronghold, so-called 社区关怀据点. Okay, and Dr. Wu is the one who designed many of the intervention tools, games. And I didn't have a slide, careful slide, but I just want to say that it's 1 month of a group activity once every week. The control group is the exercise group. The intervention group also have exercise. And we really adopt the behavior change theory. And so we're considering the trans-theoretical model and Bloom's taxonomy and various other things. Motivational interview, we all include those. And I remember we have, again, matching games for 6 fruit groups with food, bingo for nuts and seeds. And also using a plate, we put plastic food piece model into that so elder can create their own plate. Okay, and the second month, they're taking pictures of their own dinners and show it in a group, discuss that. And the third month, we discuss all the problems with their examples, their home meals. So that's what we did for 3 months, and then stop intervention. What happened? This is a stronghold. We have 13 stronghold and separated 2 groups, and finally with 225 people, and we end up with about 190 people. So there are about 30 or so people dropped out. And you can see that actually, significant increase in reduced refined grain, 白饭, white rice, and increased non-refined grain, whole grain increased, and also dairy increased, nuts and seed increased. It's very similar to the previous study. So it means that those are the places, the food groups that should be focused in Taiwan. And you can see that, you can see the, no lights, grains and on the top, the blue increase, and grain roots, protein foods similar. Dairy increased tremendously, vegetable increased a lot, fruits increased a lot, but no significance. And you can see the grip strength increase and working memory increase. So we actually have a component of a working memory in the assessment. So frailty score significantly increase, forward digit span as a working memory parameter, that significantly increase. But however, this is at 3 months. I just like to say that at the 6 month, I think the frailty score change disappeared, and also but the working memory parameter stays. So what our experience is that for elderly in the community, not 1-to-1, they will lose it if you don't do the intervention continuously. So we like to propose that to have this kind of activity, fun activity, all the time as part of their routine when they go to the community stronghold to enjoy their lunch, okay? And so I'd like to make a conclusion here. So what we observe is that low energy intake really leads to low nutrient intake in all aspects, all kinds of nutrients. It's not just protein. We should really consider all of them. And also not just the amount, but quality of diet, which can be considered as nutrient density, are also very, very important. And the healthy Taiwanese eating approach, similar to Mediterranean diet, is something we can consider. And this aspect, very likely due to because it started with poor energy intake, age-associated poor appetite, as the speaker mentioned this morning, which may be associated with inflammation, poor mobility, lack of physical activity, and lack of social life. So that would contribute to all aspects of aging-related the aging-related deterioration, and to a greater extent than those with good nutrition. So what about the method? We are providing how to optimize diet and nutrition for the prevention and management of geriatric syndrome. Well, I think we all know that improved nutrition can reduce risk of geriatric syndrome from many of the literature, and also particularly our finding from host. We can see that very clearly. And however, multiple disciplinary approach is very important to increase appetite, including companionship, including teeth, swallowing abilities, and many approaches. It's very hard to increase appetite. And in terms of quality of the food, eat nutrient-dense foods for 6 food groups: more plant foods, more aquatic foods, less red meat, and super processed food. And pay attention to personalized increased nutrient requirements, which I did not discuss today, but personally I think it's very important. You can notice that elders deteriorate in different manners. Some start from muscular skeletal system, some starts from mental, some starts from digestive system. They're all different. So we need to do assessment, nutritional assessment, to understand what nutrients are deficient. And in that kind of situation, even supplements, including vitamin, mineral, and phytonutrients or protein, can be provided when it's needed. Thank you.
Thank you very much for excellent talk, Professor Pan. So I'd like to invite all the speakers to the podium and start the Q&A session. So I'd like to ask the audience to provide any question, comment. Before people think about the question, I'd like to ask Vishan first and about the sarcopenic obesity. So sarcopenic obesity is a little bit complicated compared with osteosarcopenia. Osteosarcopenia is the combination of osteoporosis and sarcopenia, and bone mineral density and muscle mass decline in an age-dependent manner, and lower level of muscle mass and bone mineral density is detrimental to the health. But in terms of obesity, fat has some kind of protective effect in older age. So generally speaking, data indicate higher BMI is protective for adverse health outcomes. So you mentioned body fat percentage for the diagnosis of sarcopenic obesity. So body fat is total body fat. And also you mentioned intramuscular fat mass. So which is more important when you think about the, the diagnosis of sarcopenic obesity, total body fat or intramuscular fat?
I think that's a very good question and important one. I think conventionally, due to limitations, researchers have taken total adiposity. So they've used measures like fat mass percent or even adjusted fat mass. I think the limitation of this approach is that it doesn't consider the distribution. And there's data to suggest that it's actually the central adiposity, right, that's correlated with visceral adipose tissue as well as ectopic fat deposition as the key. So if we see it in that light, then a more enlightened approach can come in two ways. One is to look at measures that preferentially looked at central adiposity. We've done some work with waist circumference, but I think more recent data from the Korean group has shown WWI, the weight adjusted waist index, which is actually waist circumference divided by the square root of weight, has been shown to actually predict outcomes. The second way is actually to look at ratios, and this is the work that the AWGS group is looking at. So if we have body composition, we can have a ratio of either fat over muscle or conversely muscle over fat. And there are studies to show that this actually can pick it out better. So I think one of the work I'm looking forward to it together in the AWGS group is that we'll probably be trying to validate how this ratio works using Asian data, and again with Asian cutoffs taking the lead for the rest of the world. So very likely it will be impaired muscle strength plus a ratio. I think probably that may be the way to go. The second pertains to your comment about osteoporosis and osteopenia. And I think generally it is correct that someone who is not lean is protected against osteoporosis. But there's very interesting data, and we also have that in Jerry Labs as well. I didn't show it, is that there is a subset of patients with sarcopenic obesity who actually also have osteoporosis or osteopenia to give rise to OSO, which I presented at this conference last year. So that one of the reasons why maybe, and I think mainly from the work of Gustavo, is that the fat also goes into the bone as well. So while the bone density is okay, the bone mineral quality may be affected. So if we were to do studies such as TBS, trabecular bone score, we may actually see that the bone quality actually has declined.
Thank you. So you indicate the importance of visceral fat. Did you have data visceral fat has a higher association with intramuscular fat than total body fat?
I think our studies show that the IMAT is actually a better indicator than total body fat in terms of predicting SPPB. Yeah. So, but it was a small group. Yeah. So I think the other thing about IMAT is that it's accessibility. So while that may be done in research studies, the scalability may be an issue because at this juncture it's still largely limited to, for example, MR techniques. So I think while it can inform the understanding of pathophysiology, we still need to look for ways that are scalable for clinical practice.
Any other questions to Hui-Shun?
I'm a little surprised to find the fertility score is favorably related to less consumption of eggs and dairy products. What is this all about? And we are encouraging people to eat proteins and always say eggs are good proteins. So is there a replacement effect because the comparative, process comes out with this result?
Yeah,
or what?
I just showed the results as what I see. You know that for different study, the questionnaire has different food groups. And for instance, for Nutrition and Health Survey, dairy came out as protective. And I think the reason for the host is that because we really have very limited amount of time, we just started to do that for 2 months, and we follow the original grouping of some other papers by host authors. They group dairy and sweetened yogurt and some of other things together. So that group is probably should be separated again and do the analysis. So you can see that it's protective in Nutrition and Health Survey, but coming out, but the coefficient is not very big, it's just small. So I just show the data as it is. I have to do that, right? So that's the place we're going to reanalyze. Thank you for the question.
My question, I'm come from Taipei Medical University. Thanks the first speaker, Dr. Lin Win from Singapore, gave very wonderful and very novel information to us. I have two questions. The first question is about, as you mentioned, that is the sarcopenia obesity. So I just wonder how about in the early stage, middle stage, what your opinion? My second question is about the insulin resistance, because as you know, you also mentioned that sarcopenia also related to obesity and the diabetes that way. So how about your comment and you about related to diabetes, even the cancer? Yes, please.
I think that's a very good question. So the first question is really about some of the early features of sarcopenic obesity. I think that if we were to look at the diagram that I showed just now, there are two possibilities, the weight gain or the weight loss, right? More often than not, it's the weight gain. Yeah, in the weight loss, I think what it does tell us is that if someone is losing weight, you have to manage the rate of loss, and two, importantly, build in the resistance exercise for the prevention. Now, for the weight gain part, often this typically first appears, I think, as general adiposity, but then it starts then to show in that central bulge, what I call the Tauke sign, where we have that central belly. And then the signs that start to come along tends to, even I talk only about sarcopenic obesity, I believe they come as a bundle, right? So firstly, the knees, they get painful and you start walking less. Secondly, if one develops diabetes, again, that predisposes to lower limb sarcopenia as well. And of course, if someone has the vascular risk factors, right, that will also worsen sarcopenic obesity in terms of worsening the fat and the fat distribution. So later on, when function is affected, you could, for example, show up symptoms such as difficulty climbing stairs or doing more resistance-related activities. In terms of performance, you'll pick it up because I think muscle strength, especially on lower limb, will be one of the first to go, right? And muscle function as well. So really, I think if you look at it as a whole, what we're looking at is across the life course. It's again about the lifestyle. I believe at this juncture, it's not really about medications. I think Prof. Han gave a very good talk, I believe. And I think, especially in the context of sarcopenic obesity, even though we always say meat may be better, but I believe red meat may not be the best in sarcopenic obesity. I really think the plant-based and Mediterranean diet pattern is the way to go, especially in the context of sarcopenic obesity. Your second question was about insulin resistance, and was it cancer or just insulin resistance? Okay, yeah, so insulin resistance is actually increased. Again, I didn't show data, but HOMA-IR, which is a measure of insulin resistance, is actually much more elevated in SO and sometimes even than O itself. So it is a risk factor towards metabolic syndrome and diabetes. And in our analysis, we also showed that adiponectin is down, leptin is up. So they're giving rise to the disfavorable LA ratio. So from that point of view, if these tests are available, they also are early markers of the metabolic dysregulation that we see in sarcopenic obesity.
Okay, thank you. Give me a chance. Okay, the question is for Dr. Lim from Singapore. Thank you. Thank you for your excellent talk in sarcopenic obesity. I have two questions. One is, pleased to learn that you mentioned leucine on your slide, and which is one of the branch amino acids as well as essential amino acids, which favors insulin synthesis after ingestion, which favor muscle mass anabolic effect. Okay. However, for elderly, home base, we don't use leucine in our diet. Can you give the diet recommendation so they can have the same similar effect as from the insulin effect instead of leucine, which is expensive and no taste at all, and will decrease appetite? Okay, that's my first question. My second question is, I'm pleased to say that you show the timing consumption on your slide. However, it's not very clear to me, okay? Would you please give more details about the timing consumption of the diet in association with the exercise? Please. Thank you.
Those are excellent questions. I think that go deeper into the content. So the first is about leucine, right? Actually, leucine is available in the diet, and I checked with my dietitian colleague previously. Often I cannot remember the details, but dairy products such as egg and milk actually have it in the natural source as well. But there were some other things that were listed by the dietitian. So I will need to refer to it to check again, but definitely there are dietary sources. So what I want to actually share is that oftentimes a lot of the things that we say in terms of the good stuff, we actually advocate a food first approach. Yeah, so as opposed to taking oral nutrition supplements, the way to go is to go for food first. The reason is because this is cheaper, it is enjoyable, you eat as a community. I always joke, at a dinner party, we toast to champagne, to wine, but can you imagine we toast to oral nutrition supplements? That is weird, right? So in Asians, especially in Asian cuisine, Taiwan, Asia, rich is so good, and we need to really emphasize more on how we can use food, right, as the way to get the nutrition, especially for older people, because they trust the food more than the oral nutrition supplements. The second question was about the timing of proteins. So this is actually data from the UK, and what it shows is that if the proteins can be taken within 1 hour after exercise, that is the best time regards to absorption, because exercise itself is an anti-inflammatory effect. So post-exercise, even though the cytokines rise for a short while, but over time, exercise actually reduces the anabolic threshold and the resistance. So if you can take it within 1 hour, that is optimal, but preferably not exceeding 2 to 3 hours, because then that anabolic resistance starts to come again. Yeah. So the key is to distribute over the 3 meals, and if you have exercise, preferably it's within 1 hour after exercise rather than before, and definitely not during exercise, because it's very difficult to eat when you're exercising. Yeah.
Okay, just comment one thing about, I think maybe for the diet, for the enhanced muscle mass, maybe protein along with a little carbohydrate, which also induce insulin effect. Okay, maybe which is favorable muscle mass enhancement. Okay.
I think if someone is exercising, it is important to also keep in mind that there is sufficient calories as well. So I think calories is not necessarily a bad thing, right? It is that it needs to be matched to the exercise level. So I didn't show the graph, but in the study by Villarreal et al., the group that just had combination therapy, right? Because I said there are weight loss in 2 groups, the diet group and the combination group. In the combination group, they actually also had reduced calories. So that also resulted in weight loss as well. So if you're exercising, you have to make sure that you have sufficient calories to meet your needs. But the key is not to overeat and then to have the proteins. Yeah, so I think the message is not really about calories are bad. Calories actually are necessary as part of a healthy diet. It is that it needs to be commensurate with the energy expenditure.
Thank you.
Okay.
Testing. This is Kenneth from the Hong Kong Polytechnic University. Would like to follow up the questions for Dr. Lim about sarcopenia obesity. Two things. Firstly, when talk about sarcopenia, we have probable, moderate, and severe sarcopenia. But it seems that right now, when we talk about sarcopenia obesity, it seems like it's just one concept like SO. But whether there are potentials that in the future, then we can also classify sarcopenia obesity into different stages according to the severity of sarcopenia as well as the severity of obesity. Because some patients may have lesser sarcopenia but more severe in terms of obesity. So we have more complexity looking into this concept. Second one, because across the discussion we have mentioned about the ideas of like the plant-based diet that may provide a better source of protein, but that we may also need to encounter the issue of muscle synthesis, because in general the animal source protein may provide a more efficient protein synthesis. So when we plan for the plant-based diet. So how can we account for this issue? So these two things, what I just seek your advice.
Those are great points, and I don't think I have all the answers, but let me just try to share some general principles. The first is really about the criteria from the Aspen-ESO group. So again, we have lots of discussion at AWGS as well. Just a little bit of the background. The Aspen-ESO group was largely driven by a group of non-geriatricians from the obesity and endocrine group. So you can see that their motivation largely is based on the metabolic angle. I think as geriatricians, we are different. We actually see a lot from the frailty angle and the muscle angle as well. So we think that actually to have a holistic view, you need both. Yeah, but oftentimes when patients come to us, they are usually older and they start to have symptoms of frailty already. So when you then start to think it in that light, if you really want to stage the severity, I suspect at the end, it will be very difficult to have a unifying way. It may depend on the circumstance. For example, in a younger patient where some of the other problems and complications are at play, the Aspen-ESO is not too bad because it considers a broad range of complications, including metabolic, cardiovascular, and even the respiratory part, right? But if you start to look at it from the muscle point of view, it may make sense, and the function point of view, it may make sense to start to think of severity, for example, in terms of either frailty or the muscle function. Yeah, so I think it's something probably we'll have to discuss in a group, and guess what? You put 10 experts in a room, all 10 will have different opinions. Yeah, okay. The second question was about...
plant-based diets, how do you plan the protein synthesis issue?
Again, I'm not the expert, and I think good to also ask Professor Pan. I think there's always a tension, right, between different food groups as a whole, right? And sometimes it's debatable. Again, you put 10 people in, some will say it's the animal protein, and there'll be advocates and say, no, the plant protein does an equally good job. I suspect at the end of the day, the way I'll look at it is as a dietary pattern rather than one particular type. So for those who have animal-based, just make sure we look out for the fat component, right? And even though red meat may be better in terms of the anabolic effect, but I wouldn't really recommend taking too much red meat as well, right? A mix of white meat, especially fish, omega-3, those may be good stuff as well, right? For those who take a plant-based diet, depending on also how strict it would be in terms of the diet, if they can, I think to supplement with dairy products would be great. In Singapore, one of our favorite products I recommend to patients is soy milk, because some of the commercial products are very cheap, much cheaper than the ONS, and they are protein fortified. And when you look at the content, it is as good as fresh milk, but guess what? The fat is down. They are fortified with calcium and vitamin D, omega-3. Yeah, so I think through various ways and means, including the nuts and also some of the seafood as well, right? There are creative ways I feel that through the diet, we can actually ensure that they have enough protein. So for example, in the morning, right, if you can have milk, if they start to have a bit of tea, they add a little bit of soy milk. Those are ways that we can actually introduce some of the proteins, including, for example, cereals or even a small slice if they have, with Western diet, more like cold meats, things like that. So in the morning is to ensure that there's still the protein going in, because usually the main meal is not an issue, but it is the breakfast. The second thing for older persons is that I think in the Asian-based culture, the comfort foods are usually carbohydrates. Yeah, so for example, like my mom, right? She loves her rice and her kueh kuehs and all the things that are carbohydrate rich, right? And it's very difficult to get her to change as well. So it's really talking about using other ways to engage their generation, so they start to enjoy other foods as well, and perhaps they contain the portions of the refined carbohydrates and sugars that they are getting. Yeah, so I think the way to go is really how we can engage them in the diet pattern, beyond one food, and secondly to squeeze in the exercise, which again is a challenge as well. Yeah.
Thank you.
I know you have more questions, but time is up. So I think we have to close the session, and you can keep asking questions in the break, okay? Let's give a hand to our three distinguished speakers. Thanks for their contribution. And we are going to have a break now. Yes.
wait a moment. We would like to express our gratitude to our speakers for the insightful presentations and the discussion. So could we invite professor speakers back to the stage, and could we invite Professor Alai and Professor Huang representing our organizing committee and NHRI to express our gratitude. And we have prepared the certificate of appreciation and a small gift for our speakers.